We tried to understand our community priorities for HIE network services, and we did it in forums, but the most comprehensive thing that we did was a fairly extensive survey. The New Mexico Medical Society volunteered to have us email to all of their members a survey asking which of the network services were the highest priority to them. And then, in addition to that, the public, I'm trying to remember exactly, the Health Policy Commission of the state of New Mexico, they did a mail-out, hard copy mail-out, using essentially the same questions. So in total, we had more than 1,000 responses with respect to these priorities. And of course, as you might expect, having lab results was number one, but very, very closely behind that was the summary patient record. And then after that was medication history. After that was discharge summaries from hospitals. And after that was e-prescribing. I think that's pretty close to the list, which made it possible for us to work very well with the federal government, because that list is pretty close to the priorities that were in the NHIN trial implementations, and again, the list of the meaningful use network services that we were provided in the FOA for the state HIE network. So that was question number one. Number two was?
Great. So let me tailor number two a little bit. I think the real focus of the question relates to working with small physicians, offices, and getting to interoperability. So what was the approach that you took most often with a small group office to affect exchange?
Well, actually, it's going to be the Health Information Technology Resource Center that is developing the plans. In New Mexico, we have to bring to meaningful use more than 1,000 clinicians. We've already reached out and gotten wonderful responses from a number of the rural areas, really surprised us. More than 500 physicians in the rural areas of northwest New Mexico just volunteered to say that they're interested in signing up for the process of using health information technology to achieve meaningful use. That was so encouraging because, you know, it's a mixture. Let's face it, there's a lot of reasons why physicians have valid reasons to be concerned about making this transition. So when you see clusters of physicians that are ready to move forward, it encourages you and it keeps you going to move forward. Did that answer the question?
I think so. Let me just ask one other question. Do you have physicians that are not part of large groups today that are actively on the exchange, or are you going?
No.
Is your plan to go forward with the 1,000?
No, we're not there yet.
Okay.
Yes, yes.
Fair enough. Let me turn the next question to Keith. And the real question is, now that you've been using this technology and you've stated that you can't go back, what are you looking forward to the most?
I'm really looking forward to being able to exchange with colleagues information sets, problem lists, medication lists, allergies, with covering physicians, hospitalists, emergency departments. And I'd really look forward to the day that my patients can go on the web, enter a password, and really look at that same information themselves. And really, what I found in just collaborating in the exam room by showing them the computer screen, I can point out several misconceptions I had, changes in family history, changes in medication. So I'm really interested in improving the direction of flow, not just to other people participating in care, but in participating with the patients. I'm really hoping that we're going to get to a time where clinical decision making is going to occur in the exam room, that we're going to have protocols that I can look at somebody real time and say, I think you're at very high risk of developing diabetes or coronary artery disease. Let's work on a care plan that's individualized for you so that you can be involved in your care and participate in self-management. I think that's going to be a really exciting thing, and I'm hoping that the EHRs are going to, the vendors are going to step up and allow that real-time data interchange to take place.
Terrific. And then, Eva, I think the question is understanding the importance of having the consumer involved in creating effective services related to health information exchange. Based on your experience, what services, again, is a similar question, do you imagine that you haven't seen being addressed through either traditional PHRs or thumb drives that people should be aware of?
You mean services that would be a benefit to consumers? I think the first thing is just getting access to the information, and certainly PHRs can serve that purpose, but there's some limitations, I think, that are somewhat product-based, but also somewhat just connectivity-based, in the sense that PHRs become valuable to consumers when they are populated by information being exchanged from their physician practice. So, I mean, there are very few consumers, I think, who are going to go in and enter all of their information themselves. The value comes in having that direct connection. So I think that's something that's coming, but we just don't quite have that in most places yet. So, and when I say access to information, it kind of goes back to my previous comment about there are various ways we can provide that. And we've talked about PHRs, but some of the mobile technologies, I think talking with patients and seeing how are they using technology in their life already, and how can we build on that. That's one thing. I'm not sure about so much of what we've talked about, or what I've heard of and have heard people talking about in terms of the convenience features, like scheduling appointments and being able to access their information online, being able to communicate with their physicians. Those are all critical to patients, and I'm not sure how new the ideas are, but we still aren't there yet in terms of being able to do those things. So I think that's where I would focus, is first of all the access to information, and then being able to communicate with the physician or their provider through secure email or whatever means, electronic means is there. So I don't know, does that answer your question?
Sure. Okay, questions from around the table? Good.
Yes, thank you all for an excellent presentation. Keith, I'd like to just ask a little bit about this problem that's surfaced from implementing the EHR and then having to implement the web portal, and how that really impacts the workflow in the office, having these two separate systems that don't seem to talk to one another, but you're still giving care. And then going back to this community that you described, so how many other providers in the community have similarly adopted an EHR and similarly tried to do this piece that I think Eva was speaking to about creating access for the patient, and then also finding the absence of interoperability is a concern? Does that come up in those monthly meetings?
We're right now, in terms of our ability to work with our health information exchange, it's been heavily dependent, because of the high costs of small practices, to work with a vendor to develop linkage between disparate systems, data interchange, data repositories, immunization registries. We had to get into a partnership with government to get this covered. Right now, just on the back of an envelope, it would probably cost me $6,000, $3,000 to pay to my vendor, my web portal vendor, and $3,000 for my EHR vendor to get this interoperability that would be a tight linkage with a web portal. I think there's great interest among my patients in having a web portal to do that, but without funding and without dealing with this whole hurdle that occurs when vendors want to think of these as add-on modules. There's got to be, I was hoping that our collaborative group could convince our vendors, since many of us chose the same one, to say, okay, this is a cookie cutter approach. It's not that hard to do my office and a family practice office to allow us to get into the web portal. There's been a big improvement in my office from going to a bare bones system, which had a separate document management, fax server system, EHR, to what we're dealing with right now. We just got to get this modularity feature, the cost feature of adding on e-prescribing, adding on web portal, adding on data interchange as being something that the physician practice has to pay for and engineer. That's what has me concerned about meaningful use right now in small offices.
Eva, this is just in the same vein as the notion of the portals. Are you concerned that consumers will then have 7 different portals to log on to manage their chronic illness?
That's a really good point. Again, I think it goes back to what is going to be the value to the patient of this, and certainly access to information is one value, but we excuse me, our coalition has done some work talking about, is it just access to information, or what does it mean? And making that information meaningful and useful is a big part of that. And so I think that gets at that issue. If you've got information that's housed in several different places, and there's no way to integrate it, no way to use that data in aggregate to come up with a plan or to make that data actionable, then there's not going to be value for the consumer there. So yes, I think that would be a concern, in the sense that I think those kinds of solutions that aren't able to be integrated or aren't able to talk to each other are not going to be valued by consumers. So.
Well, I'd like to add my thanks too to everybody. It sort of depends on what, I'm John Tooker on the NeHC board. It sort of depends on what day of the week and in what form you're in. When we're talking about the HIT and then quality improvement, I think almost exactly the same questions were asked last week in a quality improvement forum, and it gets at the issue of what is the community that we're talking about. We use that term a lot, and I must admit I don't really know what we're talking about when we talk about the community. From an HIT point of view, oftentimes it's a relationship, and Eva, I think that it's just a reality most of the time now, but the relationship between, say, the hospital and physician groups within the community, and consumers may have a role. But increasingly, we're moving toward this notion of accountability within a care structure. Now, that includes health information technology, but that's a necessary piece of it, but it's not sufficient to think about accountability in a community sense. So I wonder if any or all of you could comment on, from where you sit, what does it mean by community, and how will communities be organized to improve the health care for the patient citizens that live in those communities?
I think the people that I see who need it the most, that identify strongest with the community, are the people that are themselves struggling with chronic illness, multiple physicians, different testing organization, multiple hospitals, and I'm also seeing, as a geriatrician, people that are caregivers for vulnerable elderly people. And I think I can't address all the needs of every constituency, every community, but I have to go after that first, because I found a lot of patients are feeling that they're caught in this maelstrom, that their endocrinologist doesn't know who the cardiologist, that doesn't know what the internist is doing. We've got to address that person and give them a feeling that when they go in to see their internist or family physician, that doctor has been in the loop as part of the decision making, and he or she has the tools that they need to help validate what's being done to them and to affirm that it's really being done for them.